Hello everyone. I wanted to do this video on basic ECG interpretation. Unfortunately, the meeting that I did yesterday on the rate rhythm axis did not record, so I thought it was better to do this and share. So today we're just going to be talking about the basic ECG interpretation. And with ECGs, we know that they are simply the electrical tracings of the heart. We also know, we should know this or revise this. We know that the sinoatrial node is found in the right atrium. It is the pacemaker of the heart. It does the excellent job of generating electricity in the heart, depolarizing the atrium, sending it to the atrioventricular node, which is around here, and then to the bundle of ears. This takes this to the right bundle. It divides into the right bundle branch, the left bundle branch, and then you have it transmitted through the Purkinje fibers as well. So sinoatrial node through the intranodal pathways to the AV node, through the bundle of ears to the right bundle branch block, the left bundle branch block, and then to the Purkinje fibers. Now, the sinoatrial node is 60 to 100 beats per minute. It acts as a backup pacemaker. The sinoatrial node is the pacemaker, but if the sinoatrial node now stops working, say for instance, the right atrium is diseased or the wall is too thick, what you will find is that the atrioventricular node will pick up the pieces like the assistant of the heart. So it acts as the backup pacemaker, but it can't do a perfect job like the sinoatrial node does. So it's going to give a slower heart rate of about 40 to 60 beats per minute. The Purkinje fibers can act as backup pacemaker as well. So say the atrioventricular node is not working, the sinoatrial node is not doing as it should. The Purkinje fibers, which are the lateral ends of the conduction blocks, can generate their own rhythms, but much slower, like you have seen. Now, it's just good to have these boxes in mind. Each small box is 0.04 seconds. So when we tell you a PR interval should be between 3 to 5 small boxes, it means it should be between 0.12 seconds and 0.20 seconds. The QRS interval is a narrow complex tachycardia. It's a narrow complex if it is 3 small boxes or less. The way I have it in my head is to say that the QRS complex is normal when it is narrow. So when it becomes bigger, it becomes more of a problem. And then that's where you have your wide complex tachycardia. The ST segment should be along your isoelectric line, as you can see here. And your ST, and this is what we judge our ST segment by. So here is, I'm just going to pen this. So here is no, here is the J point ideally, and the J point is the point where the S tries to join the T, tries to come back to the isoelectric line to then form the T wave. It's just good knowledge. Um, okay, so P wave. The P wave represents atrial depolarization. Normal shape, it usually should be upright and round. I discussed this in detail for those who were present yesterday. The impulse travels from the sinoatrial node, which I said is in the atrium, and the P wave is followed by an isoelectric line, which is the flat line. And from the beginning of the P wave to the Q wave is what we would otherwise refer to as the PR interval. Pardon me, not sure what that was. So back to this. Now, the QRS complex represents ventricular depolarization. Impulse from the bundle of ears trans is transmitted to the ventricular muscles. Now, don't forget, we've said from the sinoatrial node, which is the pacemaker node, impulse is generated. It goes through the atrioventricular node, right? And what you have from the period from the PR interval actually is the period from which the impulse travels from the sinoatrial node to the atrium, to the atria. The two atrium is, of course, is called atria. Now, the P wave is followed by the isoelectric line. So the PR interval is the period from which the node generates and transmits the impulse to the atria. And then the QRS complex represents ventricular depolarization. So it talks from the period, it records the period of electricity transmitted between the AV node and the ventricular muscles, and this occurs through the bundle of ears. Now, T wave is ventricular repolarization, is the resting phase of the cardiac cycle. It should be upright and round. We know that sometimes in some cases of T wave, when it is hyperacute and it is irregular, we think that then that could be the first sign of a heart attack. If it is regular and it is tented, we tend to think of we say tall tented T waves refer to hyperkalemia, right? If the T wave becomes flat, then in that case you're talking hypokalemia. So a lot of things about the T wave when the T wave is inverted. Um, and I try to give this background, even though the topic was rate, rhythm, and axis, just to revise this with you. The U wave can be an extra wave, not very clear, but it occurs after T. It looks like your T has doubled. And you can find this in hypokalemia, hypomagnesemia. Some would even describe this occurring in benign early repolarization. This would even occur in this would even occur in digoxin toxicity, amiodarone toxicity, use of sotalol. So it's good to keep in mind. Now, for those that will, I mean, there are many cases, emergency cases, where what they have is a three-lead electrode. What you need to know is that the red, R goes to R, red goes to the ribs. Then the black goes over the red and the white to the right. Lead 2 produces a positive deflection. So it is where most people, including myself, like to look at when you're looking at the P wave, when you're looking for, is there a real P wave here? Is there atrial fibrillation or what is going on here? So it is commonly used for monitoring. Now, the steps in analyzing ECG, I use the RAIC method, which I described in length, and let me know if you want me to recap that. But RAIC is first, is the rate regular, and it's basically done by counting the boxes in between each hour interval. I use the ruler. I have an ECG ruler, and if you send me a message, I will be able to link you up with one, which will help you quickly check at a glance how easy. You know that traditionally, many of us would use the plain paper and just draw the markings on each of the paper. This is the reason why I actually thought that by writing a note and taking you through a note process of presentation yesterday might work. I'm not sure it did. I've not yet gotten your feedback, but I will annotate here. So if maybe I shouldn't annotate here. We all should know what irregular is. So what I'm referring to is the number of boxes between each QRS complex. Now, there's no question too silly to add. I know I'm going maybe too simplistic for some of you, and for some of you, I am probably speaking too much or talking a bit beyond what you understand. It's okay. There's so many things you know that I do not know, and there's so many things I know that I can share with you as well. So no question is too silly. Now, a normal heart rate is between 60 to 100 beats per minute. Bradycardia is less than 60. Tachycardia, of course, we know that. Now, in calculating the heart rate, it decorsates a lot, even for me. I find myself, but how I like to explain it is, if it is a regular, if you have checked and your rhythm strip is looking regular, like the number of boxes are the same, then you divide the number of boxes between 2 hour waves by 300. If, however, that's not the case, you look at your rhythm strip, count 30 large boxes, and multiply the hour intervals there by 6, right? And in this case, we can see this is a regular heart rate. So we're able to say that there are about boxes, four big boxes in between 2 hour intervals. So we just divided 300 by 4 to get 75 beats per minute. Now, for fast heart rate, remember what you're doing is you're saying you remember in 300 you're trying to say 300 large boxes that would signify 60 seconds, which is 1 minute. So another method people do use is to calculate the number of small boxes between 2 hour waves and divide that number by 1.5. But I'm just gonna keep it simple for you. In terms of what I said, two, if it's regular, between 2 hour waves, divide the number of big boxes there by 300 divided by the number of big boxes there. If, however, you're looking at a rhythm strip and you can count 30 large squares, just count the number of hour intervals there and multiply by by 6. So this still talks about the rate. Now, this is the method 3 for irregular rhythm. And this one says count the hour waves in 6 second strip, right? Which is still 30 large squares. Sorry, 30 squares and then multiply it by 10. I meant by 10, not by 6. So you count the number of big boxes. So when I said 30 big squares, that's a 6 second strip. Now, I wouldn't waste much time talking about rate because in many strips that you have, the rate is already done for you. And it doesn't have to be this complicated, quite honestly. If you've counted your hour intervals and in your rhythm strip and you've multiplied it by 10, or you've counted the number of big boxes between 2 hour intervals when the ECG is regular and you've set 300 divided by that number, then that should be fine. But in many cases, it's already done for you. The computer has counted the rate. And many cases, in fact, 10 out of 10 or 9.5 out of 10, that rate is normal. If I am in any doubt, I pull out my ECG ruler. Rate is not something that, of course, we should all know how to count the rate, but the ECG ruler also does the job for you. Just place it on your ECG strip, and especially if you've determined they're regular and it gives you the number. Now, the P wave should be round and upright. We've told you that. And this is how you know whether a rhythm is sinus or not. So when I talk about my right method, I say there are three R's, then there's AIC. So R as in red, A as in alpha, I as in ink, C as in cat. So basically you have three R's: rate, rhythm, regularity, axis, interval, and context. And one big thing about we've learned about rate, for instance. We've already discussed regularity. But for you to know that a rhythm is sinus, number one, you've got to have a P wave before every QRS wave, right? And your P wave should be upright in lead 2, in lead AVF, and it should be inverted in your AVR. So your P wave the amplitude, that is the height, when you're talking about the square, the height of the square should not be more than 2.5 millimeter. That's 2.5 small boxes. When it is becoming taller, when that wave is becoming taller, it could signify atrial enlargement. Also, when it is wider than it should, so a tall peaked P wave would signify right atrial enlargement, while a wide P wave will signify a left atrial enlargement, so especially when it's wide and notched. Now, ask yourself, are the P waves present? Do they look the same? Is every P wave before every QRS? I always say, if you struggle, if you're trying to make up P waves in your mind, then there's probably not a real P wave there. Now, I've discussed these different types of P waves. It could be upright, inverted, flat, peaked, notched, biphasic. And if it is notched, like I said, like this number 1, 2, 3, 4, 5, like number 5, 1, that means you're dealing with a left atrial enlargement. If it is tall, it should be inverted, like I said in AVR. If it is flat, you're wondering what's going on with the atria again. Is it wide? If it is tall and peaked, then you're looking at right atrial enlargement. And it could be biphasic, in which you're looking at, again, an atrial pathology. There are several pathologies that could signify, for example, the Wolff-Parkinson-White syndrome would present with abnormalities of your P wave and especially of your PR intervals. Now, we've talked about the PR intervals, 3 small squares to 5 small squares. We routinely do not measure amplitude, but obviously if the P wave is looking bigger than normal, then you know that something is going on. Now, we've talked about this. This is the PR interval. It's normal when it is between 3 and 5 small squares, but it is prolonged when it is more than 5 squares. That's more than 0.20 seconds. And where will you have a prolonged PR interval? You would have a prolonged PR interval in atrioventricular blocks. You will have a short PR interval with your Wolff-Parkinson-White syndrome or other abnormalities with conduction. Now, your QRS complex signifies ventricular depolarization and it follows your PR interval. It should not be more than three small boxes. When your QRS complex is irregular, for example, you ask yourself with your QRS complex, is it narrow? That is it three small boxes or less, or is it wide, greater than three small boxes? And then the algorithm, which I might share, but I'm already discussing, is that is this whether it is this, for instance, is this narrow complex QRS? Is this narrow QRS complex? Is it regular or irregular? If it is regular, it's a different diagnosis than when it is irregular. For example, if it is irregular, you're looking at an atrial fibrillation or flutter. If it is narrow complex and it is irregular, you're looking at sinus tachycardia, maybe a sinus arrhythmia kind of picture. A sinus arrhythmia might not be regular, but it will have a pattern. But that is in the advanced course that I have. If you go for the fast track mastery course, that you would find notes on that. Now, to ask, are there QRS complexes? Do they look the same? Do they come after the P wave? Are the RR intervals equal? And we've discussed this. This is normal, and this is a wide QRS. If you have a wide QRS, it should alert you to, is there a bundle branch block going on? Because this shows that there is slow conduction in the ventricles. Like we've discussed, QRS is ventricular depolarization. So you're asking yourself, is there a ventricular hypertrophy somewhere? Is there a bundle branch block? What is going on in the ventricles? And T wave, like we said, it is repolarization. It is located after S wave. Now, the amplitude should be five boxes or less. The duration is often not measured, but if something is wrong with your T wave in any circumstance, I would rather you bring it up because, for instance, your T wave could be hyperacute, your first sign of a MI. It could signify Welling syndrome where it is biphasic in V2 and V3. It could be peaked in De Winter's phenomenon which is an equivalent of a ST elevation MI, and in which case you'll have upsloping ST depression. And it could signify hyperkalemia, in which you would most likely find sine waves. It could be flat in hypokalemia or even in hypomagnesemia. The ST segment, as we know, is very important, extremely important because this is one of the big markers of injury. There could be ST elevation, depression. The QT interval should I like this short thing. I mean my number three bullet point here, which says because even if you're in a hurry and you're not able to measure the QT interval, if your QT interval is looking like more than half of the the distance between your RR interval. So if you discover your QT is more than half of the time when the next rhythm starts, the next wave starts, then there is likely a problem, right? And then I discussed the QTC and BAS formula in other courses. Now the U wave, it follows the T wave. It may or may not be present. When I say U wave, I get the inkling that something is wrong. It might not be an emergency, but definitely something is wrong. So I ask myself, is it a T wave playing up as biphasic or is it an actual U wave? And with U wave, what I'm concerned about is as the person bradycardic, do they have the digoxin toxicity, hypokalemia, is there risk intracranial pressure, is it a long QT? And so many things fly through my mind. So the first reading strip to identify. Now, if you see this and you're seeing waves that look quite regular, this should signify you as an artifact. Now, I told you about my RRAIC method, rate reading, regularity, axis, intervals. I is for interval and injury, and C is for context. I always say context is king. No matter what you've done to analyze your ECG, if your ECG is normal and your patient is unwell or they have classical cardiac sounding chest pain. What is a cardiac sounding chest pain? The chest pain is constricting, it is brought on by exertion, it is relieved by GTN spray or by rest, or it worsens and worsens. I would be more suspicious of a cardiac chest pain, especially if they have age and cardiovascular risk factors. And I will not say because I have a normal ECG, I would not act. So the four most common causes of artifacts are patient movements, the electrodes are not well placed or they are bad, improper grounding, faulty apparatus. Now we've talked about a sinus rhythm. I'm not going to talk about this again. Like I've said, a normal ECG does not exclude a heart disease. And this is where we will stop for today. I hope this suffices for the lecture that I did yesterday but did not record. Do have a great day.